Welcome to this NEJM Career Center conversation, medical student influencers on MedStro. We're here to discuss the influence that medical students are having on healthcare today. Our featured guests are, of course, 5 medical students, second of 2 panels we've talked with. Let me introduce them to you. Florence Dew, Oakland University, William Beaumont School of Medicine. He's got a strong interest in engineering. Brian Powers, Harvard Medical School and Harvard Business School. Pooja Garamilli, University of Pennsylvania, after doing political science at Yale and doing a master's in health policy at the London School of Economics. Tanya Maheshwari, Touro College of Osteopathic Medicine. Ravi Shah, Columbia PNS, where he edits the Columbia Medical Review. Jordan Smith, University of Massachusetts, where she's pursuing an MD PhD. And Kim Kim-In-Ung, Harvard, an editor at Healthcare. Well, so welcome, all of you. Ravi, you proposed this series of discussions, so this is all your fault here. And these discussions run through October 29th. So what were your thoughts in proposing getting this group together? And I'm going to ask you how your new journal's coming along after you answer that question.
Sure, certainly. The idea was sort of twofold. I think one is to connect medical students who are doing innovative things and really influencing the communities around them and also the practices around them. The second is to raise a little bit of awareness on students who are influential and also to just have a discussion on ways that students can influence the practice of medicine around them and learn about how the medical culture is progressing.
Okay, so so you're the editor of the Columbia Medical Review, and you told me earlier that your first issue came out in July. Like everything starts in July in medicine. I should have remembered that. The second coming out when?
So the second issue will be coming out sometime early next year. We're currently in the process of getting submissions and editing them. So it's been really exciting to launch this journal. It took about a year to build our advisory board, build our board of editors, and go through the peer review process for the articles we currently have published.
So is the form of the thing paper or electronic?
Electronic only, so we're online.
Good for you. Okay, you don't want to be shredding the trees. Pooja, tell us about your interests in medical economics.
Sure. Well, I guess I was always interested in policy, which is why I studied political science at Yale. And I did my pre-med requirements along with that because I just quite honestly couldn't figure out if I wanted to become a doctor or if I wanted to look at the more macro level issues. So that led me to the master's program. And it was really there that I kind of got to grapple with the issues that I wanted to. So I really have an interest in developing countries, mostly because I had gone to India many times since I was little, and I had seen a lot of the issues that arise there with access to healthcare, etc. So I wanted to continue working on this throughout medical school and beyond. So I ended up, during the master's program, interacting with a lot of disillusioned doctors, actually. A lot of my classmates were former physicians who wanted to transition out of their careers and fix the more systemic issues that they faced in their respective countries. So that kind of got me questioning, but also interested again in medical school because I realized that they brought a lot of value to the discussion as well. Not only were they able to comment on real patient interaction issues, but they were also able to talk about the difficulties in clinical decision making that a lot of the health economists couldn't really understand at the moment. So that brought me back to medical school in the sense that I wanted to get that patient interaction again. But I also wanted to kind of serve as that bridge between health economics and the medical disciplines.
So these interactions that you were having with disillusioned physicians, these were taking place at the London School of Economics?
It was at the London School of Economics and the London School of Hygiene and Tropical Medicine.
Okay. And so you've you're in a position to have interesting discussions with people, with your professors clinically, when they say things like, well, you know, people should have this or that screening. For instance, today there are new mammogram guidelines out, but in the countries that you're talking about having an influence in, there is no mammography, or it's not widely available. So tell us a little bit about what influence you hope to have in things like that.
Well, that's actually a really interesting discussion. So I was actually at this conference a couple of years ago where they were talking about creating guidelines for different types of cancers and how you should go about screening or treating them in low and middle income countries. And there was a large debate on mammography because clearly we still don't know how efficacious it is even in the United States. So I think it's still a learning process, and that's something that I hope to get involved in the sense that there's a lot of room for cost-effectiveness analyses in different contexts. So I think a lot of the stuff that's been going on has been primarily focused on the so-called developed countries, and we haven't had as much cost-effective analysis done in low and middle-income countries. So that's something that I think more and more people are getting interested in, especially at the two schools I was in London. There are a lot of professors looking at randomized control trials and things like that from an economics perspective rather than, drug randomized control trials.
Well, and speaking of economics, Brian, you're taking a double degree from the medical school and the business school. Tell us a little bit about that experience and how you're hoping to use both suites of training in your career.
Yeah, absolutely. So I actually just started this past end of August, early September, so only kind of a quarter of the way into the first term at the business school. My motivations to do it, I was a humanities major in undergrad. I did kind of similar to Pooja. I was on the fence, so I did my humanities major alongside my pre-medical requirements. Ultimately, obviously, decided to go to medical school. And then kind of in between undergrad and medical school, worked at the Institute of Medicine in Washington, D.C., got a lot more interested in healthcare policy and healthcare reform, specifically the role that physician administrators in a health system can play in driving towards better care and more affordable care. And I felt that I was not necessarily as equipped as I wanted to be to go into some of the roles that I hope to in the future. That due to my background in the humanities, while it came with a lot of benefits, I didn't necessarily have the facility with financial statements, financial analysis, and that also I would kind of greatly benefit, even just as a everyday clinician, from the kind of managerial or leadership aspects of the business school. So that's kind of my motivation going into it. It's been terrific so far. Again, it's kind of just getting started. It's a great blend of kind of the hard skills that I was hoping to get out of it. So we have a class in technology and operations management, we have accounting, and we have finance all this term.
Really?
And then also kind of supplemented with a class in leadership and organizational behavior, and also a class in marketing. And I think what's probably been most interesting to me has been actually the degree to which the insights from leadership and organizational behavior certainly apply to the topic of the course and leading organizations and leading teams. But that notion of leading teams and the skills I think I'll learn by the end of that course are kind of extremely applicable not only to the team in the hospital, but also just kind of the one-on-one interactions. There's a lot about how to kind of leverage your interpersonal effectiveness to drive change, and the things that I see parallels with just kind of motivational interviewing and interacting with patients as well as kind of different members of the medical team.
So you're a first year at the medical school and at the B school as well?
So I'm a fourth year technically at the medical school, so I've completed 3 years at the medical school and then just started my first year at the business school. We do kind of a 3 years at the med school, 1 year at the business school, and then a mixed fifth year. Okay,
so that fifth year is probably disconcerting, disorienting, and everything else because you're jumping back and forth between business and clinical life.
Exactly. I think I'll be next summer when I kind of re-enter the medical world. It'll be a little jarring.
Yeah, maybe they'll let you sleep, but don't.
Probably not.
Tanya, tell us about your journey to medicine, to clinical medicine. How did you what got you here?
Well, I actually have a pretty standard path. I came straight out of undergrad to where I am right now, which is at Touro in Harlem, in New York. I originally went to Drexel University, and now I'm here. But it is definitely a non-traditional path for a lot of people. I have a lot of classmates who are in many different stages of their life. Some of them have been PAs, some of them have been nurses before, and now they're deciding to enter the medical world. So it's enlightening in that way. But yeah, it's been a very interesting journey. Osteopathic medicine is definitely a little bit different than a normal MD school, so it's kind of like having a little bit extra on the side along with the normal curriculum. It's been good.
Special sauce on the side. I mean,
special sauce on the side.
So tell us what you hope, as you think out, say 10 years from now. Where
Right. So one of the things that my school is very interested in is helping out the Harlem community and getting invested in the community and making sure that we can try to affect as much change as possible. And there are so many health concerns within this community, primarily being hypertension, diabetes. So our school is very invested in attending health fairs and setting up health fairs and setting up clinics. So how I'm involved in that is I'm currently president of our international medicine organization, and where we work with local communities. Harlem in particular has a very large Senegalese community.
Okay.
So what we're trying to do is set up a health clinic with them and get involved in that way. There's so many diverse communities in this area that that's a huge focus for our school and something that I hope to continue to work on in the future.
Okay. And Ken, you've got some editorial experience. You were a sub-editor. I don't know if that's the correct word, or an associate editor at Healthcare. What was that experience like, and did that feed you to medical school? Oh, I think Ken, your microphone is muted.
Thanks, Joe. Absolutely. I'm managing editor of a journal called Healthcare, the Journal of Delivery Science and Innovation, and Brian is an editor as well. And I got started about 3.5 years ago when I was a sophomore in college. One of my close mentors, Dr. Sachin Jain, and Dr. Amol Navath at Harvard Medical School was thinking about starting a new journal that really focuses on delivery science and implementation. So thinking about how a lot of the changes in the healthcare system now are being implemented, and the results that we are seeing in all the different models for payment reform, all the different models that we are seeing in quality improvement, in adopting new health information technology. And it's such an exciting time in healthcare. A lot of exciting research coming up, but there isn't necessarily one dedicated place where a lot of this research can be synthesized and disseminated to policymakers and to frontline clinicians. That was the motivation for starting the journal, and I was lucky to be able to help with the process of setting up the journal and launching it early on.
Who do you consider your major rivals to be for the great papers? I mean, to help, and I'm not saying, oh well, the New England Journal of Medicine. I'm thinking about things like Health Affairs, which is in itself a great monthly journal on the very topic that you're talking about.
Absolutely. I think Health Affairs is a great journal, as are many others, and I don't think we necessarily think of it as a rival relationship at all. I think there's a lot of very innovative work being produced at this time, and there isn't enough venues to publish and really disseminate the work. And I think one of healthcare's focus is really on the delivery science and implementation of research. And as you were saying, I think my interest in medicine started much earlier, much since I was quite young. I come from a family of physicians, and it was always something I was interested in. I started doing research in a hospital at the Cleveland Clinic in high school, and it affirmed my love for medicine. I found it to be what I thought would be a very rewarding and fulfilling career. But while I was working in the hospital, both in high school and then in college, I saw that there were many systemic issues, broader issues on affordability and access to care, quality and safety and efficiency that was preventing patients from getting the care that they deserve, and from healthcare providers from delivering the care that they want to deliver. There is a lot of frustrations, as was mentioned before, about the current state of the healthcare system, and with all the exciting changes right now in the news with health reform, that started pulling my interest towards thinking about healthcare policy and practice innovation and delivery reform.
So there is a lot of data out there to analyze, and so if any of your colleagues on this call have got some data to publish, maybe they can say that they were on a call with you or something. But at any rate, it's important work, and congratulations and good luck to you. Lauren, you have a strong interest in engineering, and you were working with Google Glass, according to your biography. Can you tell us a little bit about that?
Sure. Actually, it was originally through Medstro, and it was a competition that they held, and I had submitted an idea for Google Glass back in the day. I'm currently doing a startup based off of that idea, and we're not necessarily using glass right at this moment anymore because there are a lot of different headsets out there. I'm not going to say exactly which set we're using right now, but it's basically going to be a surgical application because there's a lot of technology I've noticed that, because we're all used to using it, I think our generation has just grown up with a lot of technology. So I'm really interested in seeing how medicine is going to change over the next year, over the next decades, and how it's going to impact our patients and our careers.
Now, was your undergraduate background in engineering, or did you just pick it up and along the way?
I picked it up along the way because I went to Wellesley College. It's an all-women's college out in Boston, and then I went to Boston University, and now I'm in medical school in Michigan.
Huh.
Mm-hmm.
And so you can't reveal the details about your startup, can you?
I can. I mean, there depends on what details you're asking for, but
well, so let me just say that for instance, the thing that you did with Medstro,
mm-hmm.
that project was about using Google Glass in the OR
mm-hmm.
to enable surgeons in the middle of an operation to examine, say, a CAT scan, or to manipulate things without breaking sterile boundary. And so this is basically what you're doing now is a continuation of that.
Yes, exactly.
Okay,
and
so
it's one way of saying we're used to a certain way of visualizing things in the OR, and my startup is basically taking that and kind of turning it on its head, kind of taking what we're used to, having all these screens around you, and kind of putting it in front of the surgeon instead, so everything that you want to see is overlaid on your patient and exactly scaled to your patient, because on a 10-inch screen is not necessarily the same size of the spine that you're operating on.
Well, it sounds interesting. Jordan, last but not least, you've been waiting patiently for me to ask you a surprise question. I want, and I don't have a surprise question for you. You're taking an MD PhD, and so what is your? We all know what an MD is, but what's your PhD going to be in?
So I, over the previous 18 months was working at the National Cancer Institute, looking at KRAS oncogene biology. And so 99% certain I'm going to stay in cancer biology, basic science. But what I'm really interested in is helping to facilitate asking questions about health equity in basic science labs. So really looking at the populations that the questions were asking, like who did they affect later on down the line. So I think that, yeah, that's where I'm at right now. How do you incorporate a health equity lens into a basic science lab, particularly into cancer biology?
Okay, so let me have you clarify that a bit. So health equity,
Yes.
molecular biology. So you know a lot about when.
So I can give you an example if that would be
That,
helpful.
go ahead. Go ahead.
Yeah. So we specifically know that African American women have worse outcomes and typically have higher rates of triple negative breast cancer. But a lot of the work being done is traditionally on HER2 positive or other types of breast cancer. So should that be a discussion in basic science labs at the grant level? What are the broader populations being affected by the kinds of basic science questions we're asking? And is it even a question in the lab? What's driving our science, and consequently, what drives our medicine?
Okay.
And our innovation?
And you know, there are a couple of examples recently of the driving force behind some research or some pricing decisions has been return on investment and things that I'm sure that they're teaching at the business school. But you know, looking at a question from that standpoint, from the standpoint of, all right, who's going to benefit from this, is something that you usually don't see in a basic science lab, because those
Yes.
are far away and on the other side of the bricks. Yeah. Well, okay.
Yeah, so it's a very longitudinal view, long term, long track.
All right. So let me ask you generally, all of you, you have a variety of life experiences before going to medical school, and you're forming others as you're there. What do you think your teachers are taking from you? Because teaching's a two-way street, you know. The good teachers, I think, learn as much from the students as the students learn from them. So what do you think your teachers are learning from you as a group, this generation of medical students?
Sure. So maybe I can. I came and I studied in undergrad, like Brian, the humanities, and really had an emphasis on what do people think about, and how do people make decisions, and what influences the decisions they make. The work I do currently is sort of focused on that in two different ways. So the Columbia Medical Review, we published research on medical decision making, and then I'm also, like Pooja, involved in a lot of research on cost effectiveness. And so I think one of the ways that I and other medical students have really been able to influence the way clinicians think, both attending physicians and residents, is really being critical on rounds or during medical decision-making processes about why are we making the decisions we're making, are the decisions we're ultimately making in the best interest of our patients. And I think oftentimes medical students actually are the closest to the patients in a lot of ways, and understanding the concerns and the desires of their patients, and really being advocates for their patients, and being able to influence decision making, so that at the end of the day, we're doing what's right by our patients.
So do you think that previous generations of teachers weren't so in touch with that question?
I don't know if that's necessarily true. I think that medicine has a long tradition of putting our patients at the center of how we drive decisions. But I think that medical students now are coming into medical school with a lot of different experiences from either undergraduate research or previous jobs or previous career experiences, and they're really able to bring that in to the decision-making process that happens for example, on medicine and rounds or in surgery in the OR.
Okay. Anybody else have thoughts on this question of you know, how are your teachers learning from you and from your experiences?
So I'll chip in here. I think it's really dependent on how the medical school views its students too, because at least at OUWB, I know we're very engaged with our curriculum design. I think every year that I've been here, it's been changed a little bit based on feedback from previous classes, and it ranges from really small things to how things are scheduled to larger things like including LGBT topics in the curriculum, recruiting standardized patients who are in that demographic, and that's just a lot of student demand and a lot of student interest. And there's things that we kind of do generationally differently, even within my own class. So I kind of consider my peers also teachers for myself, and the way that they've approached volunteer work or engineering projects or community projects. And even in the hospital now, I think residents are teachers, right, as well as us medical students, and our patients are our teachers. So there's so many things that go into medical education today, and that's really compounded upon because of all of the medical knowledge that has just flooded in the last 50 years. So we're at a really weird crux in history, I think, in medical education and as students, in that nobody has been where we've been before. Even though medicine necessarily will always be changing, I think right now there's just it's just a new time in medicine, and it's up to us to really decide what that looks like, and it's a really powerful moment for both teachers and students.
It seems very exciting. Anybody else want to chime in on this?
If I may, I've been lucky enough to have the experience of being at a newer school. So my school is only about 7 or 8 years old, and it can be problematic at times because we don't necessarily have, a background and have a set curriculum or something that we know has worked for a while. But it also is immensely beneficial in that we can suggest changes to professors, and we can suggest, changes to the curriculum, or very even basic, like, hey, can you upload the lectures at this point? And it'll be implemented within the next week because our school is more concerned with making their students successful in the future, so that people will, it's like kind of a business thing, so people will attend the school. So in that sense, it's really important to the professors that they're taking our suggestions, but also from an osteopathic standpoint, because we are involved in not just sitting in lectures and stuff like that. We also practice on each other. That's what we do as students. We practice osteopathic medicine on each other. So in that sense, there's a delicate nature to what our interactions with our professors, because it's not hands-on in the metaphorical way. It's actually hands-on. So we get a lot of interaction with our professors. We get close with them, and they're more than willing to hear our suggestions because of that. And with regards to not only teaching osteopathic medicine, but hey, we need to be able to learn this, and we need to concentrate on other things. So that's been an excellent experience, in my opinion.
I was talking about Stanley Reiser and his book Medicine in the Reign of Technology, and the point of his book being that physicians have spent so much time gaining the license to actually lay hands on patients and to invade the personal space, which technology has begun to erase because people now rely on instruments, or have been, rather than the laying on of hands or the interaction. What I'm hearing from this group, though, is that you're not saying so much that, we need better instrumentation for this. You're seem all to have a more bent. And so let me ask one final question, and that is the idea of practicing medicine for the public good. People like Médecins Sans Frontières, who compound was bombed in Afghanistan last month. What sort of pull does that sort of service have for any of you?
Sure. So I think that a lot of these things are probably related. We think about our patients as individuals. We have our own patients who we follow, and we're looking out for the best interests of our patients. But there's also things, for example, antibiotic stewardship, where we really are looking out for the public good. And like Tanya, our medical school is located in an underserved Dominican neighborhood, and so we're always looking to how can we best utilize our resources to benefit our community, which is already underserved in many ways. And I can speak for myself as a future clinician. I certainly think about my responsibility to my community. Certainly, global health is, and there's a lot of global health is an important issue. There's a lot of disparities worldwide, but I think there's also a lot of disparities when you look at certain neighborhoods in our own country. Our medical school and our hospital are in Manhattan, and Manhattan is some of the richest areas and the most well-served areas in the world, but we also have some of the most underserved areas in the world. And I think that if we are thinking about the Hippocratic Oath, something I think about sort of on a daily basis, and doing no harm, a lot of that does mean working hard to make sure that our patients who are underserved are really getting optimal care and getting better access to care.
Okay. We're about at time. There is plenty more to talk about with this impressive group. I would love to have the privilege of, say, in 20 years' time, seeing where each of you ends up. I think it's going to be a very interesting mix of things. I want to congratulate the profession for having selected you to participate, and I want to admire your good judgment in choosing the medical profession to enter, and it's going to go very well for all of us, I hope. I want to thank you so much for your participation today.
Thank you. It's my honor.
Thank you.
Thank you, Jill.
Thank you.
Thank you.